Welcome live from the EAO Congress in Lisbon. If you're still watching, stay tuned because you have at least 30 minutes of exclusive online content ready for you. Because what's going to happen, as Isabella Rochetta closed down the session upstairs, we have a runner next to the stage and they will bring Homayoun Zadeh and Markus Hürzeler right here into the studio, where I'm still joined by Stefan Fickel, who's a professor at the University of Würzburg and also owns a private office in Nuremberg. And you're an expert on the topic we're discussing here today. Stefan, welcome back.
Thanks, Gerrit.
Let me, before I get to you, Stefan, make a shout out to some of the participants online. Let me start with Dr. Anjus S. Parihar, who is watching us from India, who says he really likes joining in. I should say good evening to our viewers in the Far East, because I also saw we have people from Taiwan. Where's Taiwan? Yeah, it's Faker Wen. Good to see you, Faker. I hope you're still with us. And we actually have some first questions. So we're collecting all the questions right now. We'll pitch them to the speakers as they come. But I can also imagine it's been a long session, 90 minutes. So maybe some of our viewers tuned in later. So let's do a quick rerun. Session was titled, Should We Avoid Implants in the Aesthetic Zone? Stefan, what were your personal key messages that you took away from this session?
Well, I think the session was about this dilemma you have as a clinician. If I have a tooth which seems to be hopeless, I mean, this is what we have to say now after seeing the session. Should I take it out and place an implant? And we sometimes, as clinicians, think this is the only way to go. Yeah. I mean, if a tooth is lost or is hopeless, I mean, already implant comes out in our mind. And I think we had both speakers beautifully addressing that topic, showing us Homa's way to go if he goes merely for implants, and I think we already expected that. So, and he says he goes for a single shot approach, immediate approach when everything is intact, probably a trauma case, and he goes for a delayed approach, socket preservation, ridge preservation, if he sees a case with the dehiscence. And he also showed us that additional soft tissue might be helpful, especially if he sees thin periodontal biotypes. On the other hand, we saw Markus being a little bit advocatus diaboli, telling us maybe we should not be so stubborn, only seeing this technical aspect, so how to place and when to place and how much tissue. But let's open our vision as clinicians and see that there are many other options, and there are definitely options. Some of them a little more critical, some of them I think very valid options, and I think we should tackle our speakers at least with this, with these options, and asking Homa maybe, are these options for you too, and asking Mark, is the implant outdated now?
Yeah, because we learned from both speakers that obviously working in the aesthetic zone is a high stake game, right? And Homa showed us several techniques and approaches to do this properly. And then Markus came in and he literally states, this is going to be a problem, a bigger problem than it actually solves in the nowadays. And the key aspect he introduced was the fact that we now come to understand that the bones keep growing regardless what age you are.
This was one point he made, and the other point he made is that we don't really know what's going to happen on the long term. Your example, you asked me if you need another restoration on your implants placed 20 years ago. Maybe a lot of things have changed from the tissue situation, also from the growing aspect. But this was his main point, is that the implant is ankylosed in the bone, meaning it is glued to the bone, and the tooth is there just by fibers. So there might be differences, not over a year, but over 5 years, over 10 years, over 15 years, and suddenly you will have an implant infra-positioned in comparison to teeth. And well, he also focused on the patient. I mean, he said, imagine, I mean, what kind of effort will it be for the patient to restore that? And I think this is also what we discussed in the beginning, that we expect this from the session, that the speakers will tackle the re-restoration, because the re-restoration is probably the most difficult thing we have in dentistry or in medicine at all.
Exactly, yeah. So we had a broad outlook to that. And if you're joining us later, maybe you've just tuned in, rest assured that this session will stay available on the EAO channel here on YouTube. So once we've ended in about 30-40 minutes maybe, you can go back and watch the whole thing from the start. We have another shout out, this time from Indonesia, so it must be getting late at night where you are, Oni Irianto. So thanks for participating, and this is how it works. If you're watching live, use the chat function to send your messages straight here into the studio, and any moment now we will have our speakers that you've just saw in the auditorium join us live for a live debrief and a live Q&A. And let me also extend that invitation to our on-site audience. You are invited to ask your questions to the speakers as well. So, Stefan, what would you say should be the key implications in the clinical practice after watching this? How will we talked a lot about in the beginning that it's really about the decision-making process of which therapies you choose. Can we try to summarize the key decision points here?
I think we learned, or I as a clinician, I learned two things. If I choose to place an implant, I should deliberately think what is the right way to place it.
Yeah.
So when is it
so
good
this is actually of the end of the chain.
Absolutely.
If I've decided to go
but
for
also
implant,
coming back to that, it is interesting to see maybe we start too late because we start very, very technology driven. We say, okay, the tooth is lost, it's already done in our mind, I cannot keep the tooth, and now I'm thinking of how to restore that situation with implants. Maybe, this is at least what I learned, take a step back. Maybe it's not lost, the tooth, and maybe not the implant is the only option, but there are different options. And I think what hasn't been addressed so much in that session, and I think that maybe we should bring up now, is the age of the patient. I mean, of course, if you have an 80-year-old patient, probably the most simple, straightforward solution is probably the best solution. Why? When it doesn't come so much into aesthetics or whatever. But if you have a 20-year-old patient with a high lip line, maybe it is completely different. I mean, this is something maybe where I would pick a little bit on the speaker's wounds, and then later, how does the age or the expectation of the patient drive us or make us differ our decision? I think this is important. But to conclude that, for me, two things. One thing is, if you place an implant, make sure you do diagnostics, you prepare yourself. And I think Homa made a very clear point. The most important thing is the positioning of the implant.
Yeah.
So you can do anything what you can have the best implant system, whatever. If you place it too far to the buccal, if you place it too far to the neighboring tooth, you're out. Yeah. You're out of the game. It doesn't matter what kind of skills you have. And the second point Markus made, which is I think also important, is, well, let's go back from these technical aspects, go back to the more medical aspects, like treatment planning, diagnostics, like weighing of alternatives. I mean, this is a classical medical thing, what every physician, every dentist does. I mean, what is the best option in that case? Again, in my hands. I think this is also what we need to ask the speakers. I mean, for example, in autotransplantation, if you've never done this procedure, is it then better to place an implant, what you probably do every day? So I think this also comes into play. I mean, how experienced are you with a specific treatment option?
It's funny because we chatted before, and Stefan shared with me who is rooting for the tooth in an implant conference.
Right.
Are we maybe too much focused on implants here?
I think what Markus made clear, and I wouldn't say we're too much focused on implants. It could be the implant at the end, but I think we're scratching out a lot of alternatives on our mind, because for us the implant is the natural alternative for losing a tooth.
Exactly.
Why this is the case, I don't know. Probably it's very popular. There's a lot of research done on that. It seems to be easy, but so I think this is the point. This is the backbone. It's not the decision you take at the end, and we will have to tackle Markus, because I think he was a little too contra against the implants. So it may be an implant at the end, but it is probably the decision process which you do beforehand.
All right, well, Stefan, I think it's time to do that. If you're just joining us, this is the moment we've all been waiting for. The theme of this conference is A Bridge to the Future, and we've just bridged the gap for our speakers to join us here in the studio. So Stefan, step one side again. If you're just joining us, this is Markus Hürzeler, who is happy he delivered the speech, and Homayoun Zadeh from the United States. Yes.
Good to meet you again.
Oh, look at that. Great friends. We should tell our audience, you know each other from the past, you work together, you've met each other in the States.
I know.
So this is a familiar crowd. Let me also extend again the invitation to the on-site audience. If you have questions to our speakers, please step in. I have a microphone. I'll get you on the air. So congratulations on the great session. We can see in the numbers, a lot of viewership was attracted and they stayed on. But obviously we have a little debrief to do. And luckily, I'm just taking care of audience questions. I have Stefan on my side. So Stefan, we've been watching the session together. What is your first question that you want to throw on the table?
Well, of course, first of all, congratulations to both of you. Beautiful session, beautiful, educated, and entertaining also. Of course, we foresaw a lot of the things you delivered. And I mean, I have to tackle you guys, of course. You tackled each other, and I will tackle you guys. I mean, Mark, don't you see too black for the implants? I mean, you told us there are only alternatives.
I counted them. 7 alternatives you gave to implants in the aesthetic zone.
But don't you see too black? Shouldn't we put it like this? I mean, there are 7 alternatives, but isn't the implant restoration one of these alternatives? Shouldn't we put it like this?
Shouldn't we have 8?
Of course, you have a treatment process, but at the end, it could also be the implant. But I think we should think of alternatives.
Yeah, but my topic was the alternatives.
I agree.
So I have to speak about alternatives. The other thing, now I'm in business over 35 years, you know that. And if you don't make the point very clear and you are very strict, people will not notice it. So once we have, at the moment it's time to sensibilize ourselves in this direction. And if you want to make changes and make things change their mind about treatment planning, then you have to be like this, black or white. I agree with you. Implant is a good option. You know, I do a lot of implants, but I do lesser and lesser implants. And to give the message to the participants here, it's important to make it clear. Otherwise, they will not think about it.
I agree, but I'm not interested in your opinion as a speaker. I'm interested in your opinion as a clinician.
Yeah, that's what I... But listen, you have seen my last case. This was my daughter. And in my daughter, she's 20. You know my daughter well. She's 28. I would never place an implant today. This is clearly the option I would go. So, in a young patient, and for me it's young, 40, 45, we need to be more careful. After that, I completely agree with you.
Let's turn that to your co-speaker. Homa, what were you thinking? With all these alternatives on the table, would you place an implant in your daughter in the aesthetic zone?
As a clinician, it's always about risk assessment. You always have to go through the process of risk assessment, understand what are the elements of the risk for each patient, discuss with the patient, and go with a plan that works for that particular patient. So yes, we have alternatives, we have implants. It's always discussed with the patient, and at the end, a treatment is selected that works well for that particular patient. But I think the option where I disagree with Markus is that age is not always a predictor for what you describe as a craniofacial growth, because what you describe has been actually shown to occur in the same degree in the younger and older groups. There was a study, I think it was out of UK, that showed that young and old patients had the exact same amount of infraocclusion of implants versus the adjacent teeth. So whether you do it for young or old, I think that there's still going to be a complication. I had a patient in his 60s who had the infraocclusion of an implant that was placed in 10 years before, and 50s. I repositioned that implant with segmental osteotomy, and again the same thing happened to that implant. The second time it went into infraocclusion for a patient in 60s. So that could be a complication for any patient at any age. So
yeah, but there is aesthetic not the problem. But one thing I want to emphasize here, and this we have to make clear. When you take the patient too much in the decision what he wants to do, then it's very biased. Because you will convert the patient what you like to do. That's typical, that is shown in the literature. Yeah. That every clinician...
Yeah, you have your favorite
treatment.
You have a favorite
treatment, and you guide the patient in direction. This is very dangerous. And that's why
What is the danger, Markus? Because we've
because
learned
you
from...
then do that what you like to do.
Yes.
Matthias Kern, our professor about resin bonded bridge, he would always do a resin bonded bridge. He tends more to implant. But my thing, the message I wanted to give by lecture was, when you take each patient as the most important person in your life, like my daughter, then you start to think a little bit different. And you try not to be biased of what you favor. Then you think about, he would think about, maybe I sent this patient to Professor Kern, who is doing a great resin bonded bridge, to a specialist like this. And he would think about perio. You would say, oh, I can do perio than this
Markus,
guy. So this is dangerous.
Markus, reading between the lines here, the fact that you feel that you have to bring this message to this conference basically assumes that now, in the case, you think that dentists and people around us are not thinking about their patient as the most important person in their life.
It's always said like Oma is right. I mean, always we say today when we discuss about treatment planning, we say we have to discuss it with the patient. The only point I want to make, I agree with that, but the only point I want to make, we have to be careful discussing with a patient different treatment options, because the patient doesn't know anything.
We touched on the patient perspective before.
Homa, I'd like to ask you one question. I mean, Markus made it a little black and white and saying infraocclusion is a problem, and we saw that horrible case with the lateral incisor. Is that true? Do we see so many of these infra-positioned implants over 20 years? I mean, otherwise, why are we still doing implants? I mean, what is your
experience?
What is your experience?
I do agree that it is a possible complication. I also practice with a prosthodontist Daftari, who did actually one of the publications in this area, and we do see that, but the amount, I think, is not always there. It depends on the facial skeleton, and also it depends on the patient. So I would say that it's not always a complication, but we do, it's part of our consent form for the patient for the anterior area to inform him that that's a possibility. But I disagree that you have to involve the patient. Patients actually are smarter than we think. Give them credit. We are biased. Every clinician brings their personal bias, but I think the patient needs to be a participant in the decision-making process.
Sure,
otherwise, they say it's your implant, and if it fails, it's your implant, but
no,
it's the patient's.
But you have to be careful with including the patient in the treatment plan. That's what I mean. We have to be careful with this expression, because everybody is doing that.
So you say there's a difference between including, in a sense that you inform them very well about the risk and the options, but not including in what is the best treatment for you.
I mean, it's even psychologically, in the psychological literature, you can read about that, what I just said. That you will bias the patient in the direction you want, will guide the patient there. But I completely agree. I also want to take the patient in my decision. But I just want to make you think a little bit before you do that you really look at all the options, and you may have a different change in your mind when you think this patient is so important in my life. That's the only thing
I mean, the point we made, and I think that maybe concludes it a little bit, is we see a failing tooth, and the first thing we think is of titanium. And I think that was your point. Take a step back. I mean, there are other options, and maybe you end up placing an implant because you took a deliberative decision to do that. But take a step back and don't vote for the first option which comes to your mind. I think this is, what we see a little bit in your lecture.
It's not easy to convince this group here to think a little bit about not placing an implant in the aesthetic zone.
The only thing, I have one more point, Gerrit, if you allow me, which I would tackle you both, because I mean, of course we all know, and Homa beautifully showed that it's always sophisticated to place an implant in the aesthetic zone. However, my dear friend, I would say it's quite sophisticated to do an auto-transplantation in the aesthetic zone. So what about an experienced surgeon who does a lot of implants, who is experienced with an implant? Does this also make a difference in the regimen, in the treatment strategy? If I'm very experienced with implants in the aesthetic zone, of course, complications can happen. But isn't then this probably the better option for me than doing the first time in my life for auto-transplantation?
When you have more experience with this treatment, that's what you are going to do. you will bias the patient and say this is better.
Which is not bad, because
but it's
I'm more
not bad.
experienced
It's not
in
bad.
that
We have a lot of experience and you do a good job, but we have to be a little bit more honest. And you know this as good as I know. What we see on the screen all the time, is this the daily reality? This is always my question. Right.
So you're saying we're driving each other crazy with the best success cases?
They show us the nice. I do. I also show you the nice cases. The best cases you have, he too, 100%. He will show you the best cases. Let's be honest.
Did you, Homa?
He's a human being.
I showed average case.
but Homa, what is your take?
He's a human being like everybody.
What is your take on that? Would you rather go for a procedure where you think, okay, it is a critical case, it is difficult to restore aesthetics, or would you say, okay, it's possible with another option, but I don't have so much experience as a clinician?
Absolutely. I think a lot of the market options that Markus illustrated are equally technically challenging. To do a perfect endo, to do a perfect restoration, that palatal implant to cantilever that, I guarantee you most labs to fabricate that, they're going to make something that every week the patient is going to show up with a fracture.
That's your problem in the United States.
Yeah. Well,
but this is different when we have to think about our treatment plan because our lab techniques are not so good.
But that's a reality every day,
reality,
right?
That's true.
So everything is, there's no simple option. I think it's really, you have to weigh all of the options.
But you have, when you do an implant, you have 3 surgery.
Right.
And this is every time a risk. When I do, like Irena showed, what I also would favor, 1 soft tissue augmentation, pontic site development, that's it. This is less risky than do 3 surgery, for sure.
But for you, but if you take someone who's not skilled at that, they could do a soft tissue augmentation, get a sloughed and get nothing out of
but
that.
But then they get sloughed with the implant anyhow, because at the implant they have to place soft tissue too, as you said.
I think
so they have always problems.
The reality is that everything is challenging, right? There's no simple solution. Clinical dentistry in the aesthetic zone is challenging in all aspects. So we can't say these are the simple solution, implant is the hard solution, right?
I would like to go back a little bit more to the technical aspects. I mean, you showed your decision process about immediate implant versus delayed. So can we put it that simple? No buccal bone, no immediate implant?
In most situations, yes. In most situations, I think it's more predictable, at least in my view, to place the implant in a delayed fashion if it's not a facial bone. But is it always? No, there are some patients that, for a patient who's older and you don't want to put them through multiple procedures, it's not aesthetically challenging, low lip line, you could do simultaneous. But typically I would prefer to do a delay.
We are in front of a backdrop of the beautiful city of Lisbon. This is symbolic for the fact that we're also talking to 2 people from 2 very big continents with a large pond in between. We're bridging gaps here. Earlier today, yeah, I know. Earlier today we talked about, and we also touched upon that a little bit, about the difference in the Americas and the European side. Do you recognize a difference in style and philosophy in the Americas being more progressive, more aggressive, more go fast, and maybe on this side?
We have more cowboys in the US.
Thank you, very good.
But Stefan alluded
I like this answer.
This might be related to this context of both your patients and perhaps liability issues and all these kind of soft pressures going for implants and going for immediate. What is your take on that?
Well, I think US, I think came to implant dentistry a little bit later, which is kind of surprising. We have a lot of novice clinicians. So I would say the average number of clinicians performing implant therapy are the novice clinicians.
Okay.
And that's really plays into the complications that we face because they think anterior area is easy access, they would do it for the first implant. And that's where we see a lot of the complications. So I think the experience of the clinician is very important in this. So I do see the difference. I think in Europe I see more efforts to try to save teeth. But also in different countries, I find that some countries are more conservative than others, even in Europe.
And is conservative the right term, Markus, if we focus on saving teeth?
He's Swiss, very conservative.
I'm Swiss, so I'm very conservative. He's right. So
Well, but I realize there's
But the question is,
there's
if
a matter of
the
labeling
wording,
here.
The
Exactly.
wording, if this is really conservative,
Maybe it's actually
even
progressive
more
to save the
progressive
teeth.
for the future. I agree with you.
Yeah.
It's future thinking, in my opinion, too.
Let's take one of our viewer questions. It came in early already. It was Doc Andre Chen, who's watching us actually here from Portugal. And he asked, is there any evidence or any research being done on the effect of new biomaterials like zirconia and the effect on implants in the aesthetic zone? Is there any relation, anything being searched there?
There is a lot in Germany going on with zirconia implant. This is the country of the zirconia implant. But looking at the research, we need to be careful. The evidence is not there yet, what people say, that this is better regarding the aesthetic outcome, not at all. Regarding the soft tissue integration, there's no evidence at the moment to support this.
Is it to be expected though? You also rooted on stage, we shouldn't be always evidence-based. So what mechanisms are at work here why we could expect better outcome?
But this is, I mean, I don't know how it's in the United States, but you also very much now in the zirconium oxide implant.
I think zirconia has been in Europe, especially in Germany, far longer than it's been in the States. But I don't think it's always a good thing to be an early adopter of anything. I rather wait for the complications to arise for other people. I think for research it's perfectly fine, but in my clinic, I don't want to have the complications show up in my clinic as a first early adopter. So I would wait usually.
Isn't it also, I mean, probably what you guys saw over your experience, that it's most of the times never the material. It is probably your hands, how you're trained. We see that in the studies with the Century effect. I mean, it's probably not a material per se which will give us a solution for these problems.
I'm pretty sure that the ceramic implant works good. But there are other risks, we have to learn them again, and it's too fast. It comes too fast on the market, and it's before we have any evidence. And yes, in Germany, they do it over the population. It's a very, very clever marketing. They learn it from the United States. Now they go to the patient, and they sensibilize the patient that titanium is worse for them than zirconium. So this is the marketing.
So here again we have our patient.
And then the patient comes to you and says, I want a zirconium implant because I have heard in the media that it is better for soft tissue, this is better for the bone and so on. But all this data are at the moment missing, and we should be careful. But this is another strategy we are in, and we have to be careful as a profession, as a professional group, not to follow too fast all these things which comes from the media and from Instagram and from all these things. We be careful.
But if a patient comes in and wants zirconia implants, that's normally a good sign that you don't want this patient, right?
Yeah, it tells you that this patient is very sensitive. You have to be careful what you are going to do.
Well-educated Dr. Google is on the side.
He's Google educated. I call this Google or the Instagram or whatever, internet educated. There you have to be careful. I like this expression, what he just said.
Talking about Instagram and YouTube, we are live on the EAO channel, and we have Ibrahim Samir Rabe who's joining us. I don't see from where, but he's very thankful for your story. He wants to congratulate you, and he concludes it as that it's basically a matter of multidisciplinary teamwork. That's the answer to all of this. Do you agree, Homa?
Yes.
Glad. Otherwise we could have a live debate.
Yeah.
But it actually also brings us to the end of this half-hour debrief. So thank you very much for your active participation. Thank you very much for joining us here on the EAO channel. Thank you, Homayoun Zadeh. Safe Congress and safe travels back to the US. Thank you, Marcus. Thank you, Stefan, for being my expert co-host. And I hope by now you've already hit that subscribe button here on the EAO channel. And make sure you tune in back with us either tomorrow morning, 8:30 Portugal time, which is 9:30 in the rest of Europe, and in the afternoon in the Far East, for a breakfast news. And later tomorrow at around 10:30 we will cover live the plenary session number 2, I'm still busy Marcus, about how to treat cases involving buccal bone loss after extraction. So I hope to see you back here tomorrow.